Great. Thank you very much to the organizers, to the chair people for asking me to present some cases. I'm going to ask our presenters actually while I'm talking just to kind of come up to the panel because while I think our chairs have had some questions that have brought some of these together, I'm hoping that we can pull a couple of these issues in this disease together with a couple cases. And hopefully dive a little bit deeper into some of the questions that came up during the presentation. So again, just as everyone's getting settled, these are my disclosures, I hope. And so we'll begin first with a case. I have three cases. We may not get to all three of them, which is fine. They increase in increasing complexity, but we tried to pull cases that are multidisciplinary in nature. We start with a case of a 60-year-old male who is an ophthalmologist, which automatically means that he will likely have a complication at some point in time and has significant opinions on how his disease should be managed. He's known to have hepatitis B for several years, well controlled with therapy. He had been sort of non-compliant in screening, but in 2016 had a CT scan that showed a 1.8 centimeter lesion, and regrettably follow-up was recommended only. Now, this is at an outside institution, a small center, and he underwent imaging in 2018 again that showed that this lesion had grown significantly to 4.8 centimeters, and it was diagnosed as HCC and deemed by his local surgeon to be unresectable. So we'll just scroll quickly through the imaging here. Again, we're not going to be quizzing on any anatomic issues here, but really just to kind of show that he's got a lesion kind of posteriorly there in segment 6. We can run through that again. And again, I think that probably Dr. Salmo, as an interventional radiologist, probably feels both on a diagnostic side that maybe they were slightly off in the interpretation. So again, it was deemed unresectable. There was no really helpful clinical biomarkers. He underwent upper and lower endoscopy as per protocol, and this was normal. And he's treated with chemoembolization with a doxorubicin-based regimen. He had significant pain post-treatment. On his first follow-up scan, he still had residual enhancement, and so underwent repeat TACE. And then underwent repeat imaging and was diagnosed locally with progression to multifocal disease. So this is just our follow-up imaging after TACE, and you can again see that there's probably a little bit of decreased enhancement in the lesion, but numerous peripheral lesions that were diagnosed locally as multifocal progression. So he obtained a second opinion, moving slightly closer to our institution, but not getting there. He underwent an endoscopic ultrasound and biopsy that showed that this lesion was actually cholangiocarcinoma and had a positive portal lymph node. So what now? So we addressed the issues. First of all, I want to ask Dr. Salem about the doxorubicin-based. Would you anticipate any activity for doxorubicin-based chemoembolization in this disease? Is there any data? I know you showed a number of agents, but any evidence for doxorubicin-based?
So it's as I mentioned, this is all sort of retrospective type analyses. We get lucky, we get a couple that we treat, and we'll look at the data. In general, we have seen a little bit more in sort of biliary injury with the drug-eluting beads compared to conventional TACE. That sort of has been something that we observe. I think he actually had some of that injury in this case. That's why he had pain. And it doesn't surprise me that it wasn't completely treated as well, because it's a posterior sectoral lesion, which means the right inferior phrenic artery is probably also contributing, which means it probably missed some disease as well.
Excellent. So now we brought up the issue of portal lymph node positivity, and I would like to, I know Dr. Lang, maybe we'll get his comments first, because he alluded to this in his talk. If before resection you know your portal lymph nodes are positive, does that change your approach?
No, usually not. Initially, I thought it was resectable. It was a solitary lesion. Why not resect it and then do lymph node dissection? Now, the positive lymph node would not prevent me from resection, but of course the multifocality of the tumor. So it's multifocal tumor in the right lobe and the positive lymph node. So resection is a little bit more, the prognosis is poor after resection. So I still don't know whether I would resect. Probably I would go for chemotherapy first and then resection.
So consideration for chemotherapy. Professor Chow, what about yourself?
Yeah, I share that opinion. I think initially, number one, it was resectable. It's posterior segment. It's quite straightforward in a fit patient. And secondly, I think based on the radiological diagnosis, I wouldn't have called that an HCC because I don't think the patient fulfills the requirement of an HCC. But now that he's been treated so many times, he's multifocal now and so on, I think surgery is unlikely to be curative now. So I don't think it's wrong to give other therapies in front, for example, either chemotherapy or of course my bias will be radiation with radioembolization, and then we resect after that. But I think the patient missed the boat the first time around. Yeah.
Sure. So I wanted to maybe Dr. D'Angelica can comment a little bit about, we alluded to a little bit in terms of the issues of surgical margins in resection. We've had progression in colorectal liver metastases towards parenchymal preserving procedures. Given that these tumors can often be infiltrative and invade sort of portal venous structures and have intrahepatic vascular invasion, any evidence to sort of favor one type of resection over another?
No, I don't think there's any evidence. I think you should, first of all, if it's invading a vessel, the problem is not the margin, the problem is systemic dissemination. So I don't think you can turn that into a technical problem. Of course, if you're going to bother to do surgery, you should completely resect it. So obviously you'll have to do some sort of an anatomic resection if that's necessary. Personally, I think you spare the parenchyma to save the patient from the morbidity and mortality of a major resection if you can. But I think you just need a complete gross resection of the tumor, and that's determined by the location. This probably would have required a right hepatectomy in my hands.
Any other members from the panel in terms of when they are planning a resection, the size of the margin that they plan on, or is R0 sufficient?
I think the data clearly shows that the most important challenge is R0, and that's because of the nature of the tumor. Some of them can be very infiltrative. So it's not really anatomical or non-anatomical, and I share the opinion that we should try to preserve parenchyma. And of course, once you're in the vessels, it's not a surgical issue. It's a systemic disease, that's where we fall short because we don't have very good systemic therapy drugs today.
Okay, great. So again, just kind of reviewing these, he finally got to our institution and we looked very carefully at these sort of intrahepatic progression. And we actually think, as Dr. Salam alluded to, that these were actually ischemic phenomena and biliary injury rather than, and again, points to really the importance, and maybe the panel can comment on the idea of having really centralized care for these type of diseases and how dependent we are not only on our interventional radiology but by diagnostic radiology colleagues. So again, he sought a third opinion at our institution, and again, just as they said, we proceeded with resection, and I agree with many of the stated opinions that we proceeded with a posterior sector resection and portal lymphadenectomy, and in fact on pathology was revealed as an intrahepatic cholangiocarcinoma moderately differentiated with 1 out of 6 lymph nodes. So again, I think points to a number of the issues. So we did come up with this, Dr. Lange alluded to this, but maybe we can get the opinion of the rest of the panel. What is an adequate lymphadenectomy? Is 6 nodes sufficient, 3 nodes sufficient? We all know that, unfortunately, I don't think we get as many nodes as we think we do or plan to or hope to, but when you see that pathology report, where do you feel an adequate lymphadenectomy is?
So I think the number of lymph nodes is adequate. So in literature, there is some agreement that it should be at least 6 lymph nodes. Maybe it's enough, but it's the question, where are the lymph nodes from? If they are only from the hepatic hilum, then I think it's not enough. You should at least remove the lymph nodes behind the pancreas. It was a right-sided intrahepatic cholangiocarcinoma, and then you very often have positive lymph nodes behind the pancreas. So it's not only a question of the number, but the location of the lymph nodes.
Okay. Dr. Chow, any comment? Is it your practice to cocorize the duodenum and get the retropancreatic or periaortic lymph nodes?
So what I'll do for a case like that is that I'll go behind the pancreas and sample first. And if it's positive para-aortic, this is M disease. and I may or may not proceed.
Para-aortic is M disease, but not behind the pancreas.
Yeah, not behind the pancreas, that's right. So we'll do that. But of course, in a fit patient, we are usually also very tempted to proceed with the resection anyway.
I think we have to be very clear what we're doing with the lymphadenectomy. I dare anybody in this room to show me proof ever that a lymphadenectomy has improved survival. Go ahead, show me. Randomized trials in just about every single cancer we've ever treated. So we have to understand very clearly what this is. This is a staging procedure. If you're helping people, it's a very small group of people. So, I mean, this is we get obsessed with the number of lymph nodes. I can make them look like 7 lymph nodes by cutting them in half. And also the pathologists don't always find all the lymph nodes. It's a matter of whether you've cleared the porta and the areas that have been discussed completely. Sometimes that's 3, sometimes that's 15 lymph nodes. And so I don't think you have to be obsessed with the exact number of lymph nodes.
So I think, yeah, there have been some attempts really to add to, in gallbladder cancer to advocate for the therapeutic benefit of lymphadenectomy, but really it amounts to some statistical gymnastics. We've addressed the issue of adequate margins and adjuvant therapy. Is anyone we obviously look at the results of the recent trials. Anyone offering anything other than capecitabine in adjuvant at this point in time?
No data.
Just one question. Was it a solitary tumor or multifocal now?
This was a solitary tumor. There was no satellite or additional lesions.
So the rest were abscesses, were dilatations, and so on.
Yeah. They were ischemic biliary, combined ischemic and biliary injury. So I think that we can move with a second case if the chairs allow. This is a 47-year-old woman who presented with...
May we ask some question to this first case?
My apologies. Yeah.
Thomas Grimberger from Vienna. 2 questions. First of all, you have not shown us any MRI pictures from that patient. And we have a quite experienced panel which sorted out this patient to be multifocal based on your CT scans.
These were MRI, sir.
All right, so can you show us where the single tumor is? Because it was
right here,
suspected to be multifocal.
That was on an outside interpretation of the imaging.
All right. Second question would be, it was supposed to give neoadjuvant treatment or give chemotherapy to see if the patient can be stabilized. So what chemotherapy would you give? The panel is a question to the panel.
Sure, okay. To the question to the panel, if knowing the lymph node positivity, if you decided, I think Professor Chow brought up the idea of preoperative therapy. What preoperative therapy are people providing?
So I think in Singapore, for cases like that, the preoperative therapy would be radioembolization, because in our experience, that gives the most ability to regress the tumor. In fact, our medical oncologists will not give chemotherapy before surgery for cases like that.
Why not?
It doesn't work.
The point of chemotherapy is not for it to work. The point for chemotherapy is to show you the underlying biology.
Yeah, Y90 does that very well and shrinks the tumor at the same time. So we'll prefer that. And less toxicity, single shot. The patient comes once.
Dr. Salam, do you want to weigh in on the idea of systemic chemotherapy versus Y90 as showing your disease biology?
Yeah, I mean, I think that's something that we've been working on, particularly in the HCC setting, particularly when you think about the limitations of portal vein embolization. So we've believed in that. We think it's akin to a 6-month waiting list for transplantation, and so we like the idea of something that also treats the tumor with a good cytotoxic effect.
Okay. So thank you. Thank you for that. Okay, so we'll begin with next case will be a 47-year-old woman who really unfortunately developed fatigue, and she underwent ultrasound followed by CT scan that demonstrated these lesions within the liver. Again, this is a CT scan. We do have MRIs available for further along in this case. But to show you a few key images, we have a lesion here in segment 7. Again, looking relatively infiltrative. We have a large lesion occupying the center of the liver with, it looks like some slight distortion of the inferior vena cava, and there is a final lesion here in the caudate lobe. So again, just to review the imaging findings, and again, unlike the previous case, this was relatively consistent with findings. There's an 8.5 centimeter mass in the center of the liver, encasement of the right hepatic vein, right portal vein, right lobe atrophy, left lobe hypertrophy, an additional 1.7 centimeter lesion in segment 7, a 0.9 centimeter lesion in segment 1, and no radiologically significant lymph nodes. The CA19-9 was significantly elevated at 2,700, almost a CEA of 30, and upper and lower endoscopy are negative. So questions for the panel, and again, I think Dr. Lang alluded to this, and maybe he wants to start off with this discussion, indications or considerations for resection in patients with multifocal disease.
I think from the technical point of view, at least assessing the pictures you showed, it is resectable. You could do an extended right hepatectomy. Of course, it's at least 3 tumors, and then you could also consider preoperative chemotherapy to see the biology and then to do a secondary resection. But initially, I think it's resectable.
Okay. Dr. Salam, any points in considering multifocal disease and Y90 in terms of technical aspects, dosing from that regard?
Yeah, so this is my favorite type of case to treat when it comes to a potential resection patient, because yes, it's multifocal, but it's unilobar. And the idea here is that this person would get a high-dose lobectomy technique along with an infusion of segment 4 that will create in the operating room sort of a radiologic and a scarred cantilever line that our surgeons have cut right across. And that segment 2-3 will be significantly hypertrophied. And so for me, this is a very interesting area of research in the neoadjuvant setting.
Anyone else want to weigh on this topic, approaches to multifocal disease?
So we have a clinical trial running now that will give the patient Y90 followed by GEM-CIS. And patients like that will probably do that and enroll in the trial. And if they regress significantly, I think then resection will potentially be curative. Because my surgical colleague has said, we can resect now, but chances of the tumor coming back is almost guaranteed. I think.
Yeah, I think we have to be really careful before we conclude that we should resect multifocal intrahepatic cholangiocarcinoma. Those patients have a near 100% recurrence rate, and if there are alternative ways to control the disease, it's probably better. So for you to think that those are the only tumors in this liver, that's obviously naive. This patient has tumors throughout his liver. It's just that you can't see them. So I don't think we should necessarily conclude. We rarely operate on multifocal disease because it's a technical exercise. Sure, you can do an extended right and caudate resection in this patient. That has a mortality of 2%. I don't care who does the operation. Even if you do it very well in the most experienced centers, that's probably the best. And secondly, we have regional therapies that work. And this is a regional problem. This is not a local problem. This patient has a whole liver problem. And so, I mean, for us, this is a great indication for regional chemotherapy.
But there are, I mean, cholangiocarcinoma is prototypical disease where there's a 10-15% patient population you as a surgeon want to find and you want to resect and potentially cure, right? You agree with that?
But why not after
Of course you agree.
Right. And so once you treat them, you're right, Mike, you're going to see the recurrence is going to be in segment 2-3. That's always the way it is. But when you have a technique now where you can potentially treat, potentially get some tests of time, identify the best patient, and then you can cure them. That's what you're trying to do. So we agree.
Yes. Why not go for resection maybe after 3 or 6 months if it's controlled and the left lobe is still free?
Yeah, sure.
Because it's not free.
So we had the suggestion of combining Y90 with systemic chemotherapy, and so I've heard the skeptical view, and perhaps maybe members of our panel can comment as to the penetration of systemic therapy into the liver after embolic techniques, radioembolization.
Maybe Riyad should talk about that.
Sorry, I don't understand the question. What is the
Sorry.
question?
So I've heard, again, I'm not espousing this opinion, but I've seen it expressed as to what kind of systemic penetration into the liver of systemic agents you would expect after something as aggressive as radiohepatectomy. Or is it? Or are you hoping it's just the effect on the contralateral side?
Maybe I'll take this question. I think radioembolization is in many ways a misnomer because in radiation therapy, we don't try to block arterial flow because we need the oxygen to keep coming in to bring in the oxygen radicals so that radiation actually works. I think the term was created by Riet because people understand TACE, but they don't understand selective internal radiation therapy. But essentially, the two therapies are different because the sizes of microspheres are very much smaller than that of TACE. So in fact, there's no attempt to block the arterial flow. It's just to bring radiation right into the tumor. You need the oxygen to keep coming with that. So you will not actually embolize the artery, so to speak. So chemotherapy can still go into the tumor.
Okay, Dr. Salam, do you want to, you're okay?
Yeah, I mean, when you talk about embolization and chemotherapy, I don't really have any information on that. I think the debate is when you do like a large particle embolization, can you do Y90 behind it, or should you do small first and then larger particle? That's where the debate comes in.
So if we're going to, if we're going to offer neoadjuvant chemotherapy, what are people offering in first line in terms of systemic therapy? You mentioned Professor Chow mentioned gemcitabine, cisplatin. Anyone using any other agents in this space?
Pump chemotherapy.
Okay.
Very reasonable to do in a patient like this.
All right. And based on French data, anyone using oxaliplatin-based regimens? Anyone in the audience feel there's any activity on oxaliplatin-based regimens? Okay. Something we may want to look for in the future. Prognostic value of CA19-9. I think we've all seen cases with relatively small volume disease, but significant elevations in the CA19-9. You see patients with high volume radiologic disease, but modest elevations. We all know there are CA19-9 non-producers, but prognostic value of CA19-9 and how you're using that in your decision making. Anyone on the panel? Dr. D'Angelico?
The data is not great, but it's, when you have these kinds of tumor markers of tooth in the thousands, that just gets to the point of what I was saying before, that it is somewhere else, you just can't see it.
Okay.
Same, I mean, pancreas cancer is much better data on the CA19-9. I mean, you'd avoid operating on a pancreas cancer patient with a CA19-9 this high. It's probably similar situation here, although admittedly the data is not very strong.
So I think, again, just to conclude this case, because I think we're running out of time, there's on endoscopic ultrasound, there's no suspicious nodes. They did biopsy a number in sampling, and those were negative. We gave 8 cycles of gemcitabine and cisplatin. We had a nice response in CA19-9. And then because there was some concern about surgical margins in segment 4, there was external beam radiotherapy given with a further decrease in CA19-9. And we've not really addressed that. Obviously, we've talked about the great advantages of radioembolization, but external beam radiotherapy has not come up in our discussions. And so anyone in the, Professor Chow, anybody in the panel, Dr. Lang, anyone in the panel using external beam in the preoperative setting?
Oh, preoperative now, sorry.
I think our Japanese colleagues have some experience using external beam, but I think what we see here is not only external beam, it's proton beam.
Yeah.
So I think the disadvantage of external beam is that you can't really deliver the radiation dose that you need because you get a lot of collateral damage, but proton beam changes the picture, and proton beam is a potential game changer because it can potentially even be better than radioembolization in delivering a radiation dose that you need directly into the tumor. But so I'm quite interested to see this patient being treated by proton beam. It's not widely available.
Okay. Dr. D'Angelico, you had a comment maybe using it in the postoperative?
So we have a guy named Christopher Crane, who was at MD Anderson, and is working with us now, and he has a very impressive series using ablative, not proton beam, but ablative high-dose radiation for these patients, not as a preoperative dose, but as a definitive treatment. And his outcomes are actually remarkably good, much better than anybody. I would invite anybody to look at his publications. I think it's very preliminary to say much about it, but once in a while, when we use it in these very advanced patients, where there's reasonable amount of parenchyma to preserve, and he will essentially ablate the rest of the liver and the tumors with radiation.
Dr. Salam, final word with you in delivery of radiation.
Yeah, so the same principle applies with Y90. We've been applying ablative therapies now for 10 years, and we can get some curative outcomes. The issue I have with the external beam data is we speak a different language. They speak local tumor control. We talk time to progression and PFS, and they don't really describe OS, and it gets a little bit difficult to compare outcomes. There's no doubt that proton beam changes things, but I just wish we could get into a normalization of what the outcome actually is, because, I mean, a lot of therapies we all apply have a local tumor control of 90, 95%, and so I think that there has to be that normalization, then we can start comparing.
Okay. Great. So again, this was, the patient had, I think, a reasonably positive response. You can see some hypertrophy, again, continual hypertrophy of the left lobe. We had a positive response in the disease with actually radiologic response by EASL and RECIST. And then after this kind of response, is everybody happy to proceed to resection? Are there still people who would give more therapy, more test of time, running?
What's the time between start of the treatment and the CT scan now?
6 months.
I would consider surgery now.
Good time to do surgery now.
Yeah, this is we have to be really careful about how we define this. This is the exceptional case. So when we talk about surgery, we've selected this patient out to be an exceptional responder. This is an uncommon response to gemcitabine and cisplatin. This is a very small percentage of the overall patients. Obviously, this is the patient to start breaking the rules in. We're set up for this answer, but you have to realize this is uncommon.
Okay, so we did proceed with resection, and again, had a successful result in that negative margins, poorly differentiated adenocarcinoma with a 7.3 centimeter lesion, and obviously the satellite lesions and node negatives. I think at that point in time, I think we'll conclude. I definitely want to thank the panel for their contributions. Obviously, it's a success when we can get into lively debate. Of course. And thank you again for the opportunity to present.